This is really going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
For MedStream 360, we'll be extending 24-hour live cases so that you can watch cases in your own time zone, time frame at your own convenience.
MedStream 360 is a transformation in medical education. With MedStream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of MedStream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make MedStream the most beneficial.
Concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field. And the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to MedStream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.
Okay, hello everyone. Welcome to Harbin, the first affiliated hospital of Harbin Medical University. We are happy and privileged to join the MedStream 360 to share our daily cases and our experiences. Today, we are really happy to share the case of a very unique, very complex chip patient. And I'm going to introduce the leading operator of today, Professor Zhao Jiyi. And the second operator is Professor Dong Guo, Professor Sun Danghui, and I'm the moderator for today. I'm Dr. Cao Yang. Okay, I will give the rest of the time to Professor Dong Guo to give a general introduction of the case.
Okay, thank you. Okay, hello everybody. Let me introduce this case. Next. This is a 64 years old male patient. I suffer from chest pain for 1 month. Risk factors: hypertension for 14 years, diabetes for 10 years, and the echo shows us left ventricular diastolic dimension is 60 millimeter, and the ejection fraction is 36%. Okay, next. This is laboratory data. And you can see glucose and NT-proBNP a little bit higher, and TNI this time is very high. Next. ECG show us elevated ST segment in leads V1 to V3, and depressed ST segment in leads 1 IVL, and V5, V6. And you can see negative T wave in leads 1 IVL and from V3 to V6. Okay, next. This is the angiography data on the June 6th at the local hospital. And from the imaging, you can see very long diffuse stenosis from the middle to distal circumflex. And the diameter of circumflex is very small. And from this imaging, you can see from the distal to the middle, left anterior descending, there are very serious stenosis with severe calcification. Next. From this view, you can see the calcification. Next. And there are a stenosis at the distal left anterior descending. Next. Okay, next. This is a right coronary artery imaging. Almost normal at the there are middle stenosis, mild stenosis at the proximal to the middle. Next. You can see there is a contralateral flow to support the distal left anterior descending from the right coronary artery. Yeah. Okay, that's all.
Okay, maybe Professor Zhao Ji is going to introduce the angiography of today and also the strategies for the current PCI procedure.
Thank you. Hello, everyone. I'm Zhao Ji. For this patient is a high-risk patient. He has several risk factors, just like hypertension, diabetes, chronic heart failure, old myocardial infarction. His ejection fraction is 36%. This is the angiography today. We can see in the proximal OM and the distal LCS, there is serious stenosis. We can see the severe stenosis and calcification in the proximal LAD. So his lesion is complex. It's very complex. The distal LAD vessel size is too small. It is not fit to CBG. So, based the examination results for this patient, we will plan to perform intravascular imaging guided PCI on LAD, on router or IVL. We will use IVAS to assess the type and the severity of calcification of LAD. We will use IBP to keep blood pressure and heart rate stable. That's all. Thank you.
Okay, thank you, Professor Zhao. I think that for me, this is a relatively very complex case. And this is a relatively elder patient with a lot of risk factors, including the hypertension, diabetes mellitus. And we can see this is a triple vessel disease, the distal RCA, PDA, PLV, and the diffuse, the lung severe stenosis with calcification in LAD and circumflex. So this is a typical CHIP patient. So like Professor Zhao indicated that the left ventricular support system, for example, in this patient, we implanted the IABP before we touched the patient, which is relatively very important. And after the initiation of the IBP, we can see that the blood pressure, the heart rate of the patient all get better. So this is the base of the patient. So maybe Professor Zhao, you are going to introduce what we have done currently, I mean, for the patient.
The distal LAD is too small. We use 10 balloon to inflate the distal LAD. We use 105 millimeter balloon to inflate the proximal LAD. This is a severe stenosis. Then we use IVLs to assess the type of the calcification in the proximal LAD. Please, Professor Cao Yang, explain the results of the IVLs.
Okay, thank you, Professor Zhao. I think that, like Dr. Zhao Ji indicated, that we touched LAD first because this is our target vessel for today. There are several indications for this patient. One thing is that we know the left ventricular function for this patient is not so good. The EF, value is 36. And also ECG and the ultrasound also indicated that the anterior wall of the patient suffered old myocardial infarction before several times. So I think that the recanalization for LAD is of key importance for this patient. Not only just recover the left ventricular function, but also it's a good prognosis for the patient. So like Dr. Zhao Ji indicated, after a 1.0 balloon predilation, we use IVUS to check the plaque burden distribution as well as the calcification of the LVD lesion. And also, I think that one key information in this case is that this kind of IVUS system that we use is an 100% domestic, which means that this kind of a machine and also the software is made in China. This machine, we can see that the software, this kind of machine is 100% made in China. It's called the Insight Left Tech, which is developed by the Beijing companies in our China. So we can see this is a pullback from the mid-distal LVD to the proximal part. And we can see this is a 60 megahertz, IVUS image with over 100 frame per second. So this is a relatively very clear, the imaging is not so much blurred like what we see from the 45 megahertz imaging catheter of IVUS before. And also there are several advantages of this software. First, one thing is that the pullback length is relatively very long. It's a 1.5 millimeters, 1.5 meter, length. So compared to the traditional IVUS imaging system, the length is 99 centimeters. So this is a relatively super length of the pullback, which engage for the relatively long diffuse lesion like this one. Let's check the image. We can see that there is relatively a lot of concentric fibrotic with a superficial calcification, very high plaque burden with a lot of, we can see, attenuated plaque. So I think that what Professor Zhao has stated is quite a wise and a very good demonstration for relatively high risk CHIP patient like this one. We can see the patient suffer diabetes mellitus, hypertension, and we detect a lot of supracalcification with attenuated plaque. This is a relatively high predictor for the slow flow and non-flow phenomenon. So we can see that Professor Zhao didn't use very large balloon to make a predilation at high pressure. I think that this is a key information to guarantee the good prognosis and also the procedure success in this patient. So we can see that there is a lot of superficial calcification, especially as a most severe part. We can see there is some attenuated plaque underneath the superficial calcification. And also we can see there is something over 270 degrees of superficial calcification. However, one thing should be noticed that although the calcification angle is relatively large, I think, majority of the audience should agree that this is a circumferential calcification. But we can see the diameter of the vessel is relatively also large. This is a, I mean, how to say, for me, this is a pain spot in this patient, because if we use rota for this patient, I think that a 2-millimeter burr doesn't touch the wall very well. However, on a 5.3 millimeter square for the proximate LVD doesn't meet the how to say, our good cutoff value for the good prognosis. So this is a very painful, I mean, troublesome spot. So I think for this kind of current situation, I don't think rota is going to play a great role in this patient. So how to treat this kind of relatively large angle superficial with a circumferential calcification is a good question. Let's going to see the rest of the pullback from the LAD. We can see a long diffused eccentric fibrotic with the superficial calcification plaque burden. This is a high plaque burden. So we know that the patient suffers diabetes mellitus, and the stent is going to be relatively long. We can see some echolucent plaque beneath the superficial calcification. And also as a proximal part of the LVD, we can see some clear landing zone. So this is a good information, because maybe the proximal part of the LVD will have some good landing zone. We do not worry too much if the stent needs to be protruded into the left main or not. This is a bifurcation joint inside, and this is a proximal part of the LVD we see from the angiography. This is a potential, proximal part of the landing zone. So this is the pullback from the proximal part of the LVD, Professor Zhao.
Thank you.
So, Professor Zhao, what do you think next step? What should we do to treat the calcification we detect by the IVUS? Because we can see some circumferential, especially at the most, severe stenosis part. However, we just talked that it doesn't seems to be good indicated for the rotablation system.
Based on IVUS results, to avoid no flow, slow flow, we selected IVL to treat the proximal LAD calcification lesions.
Okay. I think this is a very good choice, because what we talked before, one thing is that this is a long diffuse lesion with a relatively lot of plaque burden, and also from the IVUS image, I think that gives us a very important information. One thing is that we can see there is a lot of attenuated plaque, and also the lesion length is relatively long. One thing we also should notice is that this patient, as a mid distal part of the LVD, there is a focal severe stenosis with a relatively small, vessel caliber. So this is also a troublesome, because during the rotablation, operation, if some sparkles, some small plaques, got falls off and was flushed to the distal part of the LVD, maybe there is a potential of the high risk for the slow flow and non-flow, phenomena. And also, if you pay more close attention, you may detect two relatively very large and very important bifurcation of the diagnose at the severe stenosis part.
ATM.
So, like what we have seen, and Professor Zhao is performing the IVL system. So we can see after the plaque modification using a 2.0 balloon to make the plaque modification. Now we are using an 3.0 millimeter IVL balloon, which was distributed and sent to the most severe circumferential calcification part to make this shockwave therapy for the circumferential superficial calcification.
Right.
4 ATM.
Yeah.
Okay, we can see that Professor Zhao has already finished the first round of the shockwave for the most severe part. We can see this part maybe at full atmosphere. The balloon doesn't open very well. I think this is the sign of the restriction of the calcification. And maybe later we may check again after the IVL to check the superficial calcification situation after the IVL system. So there are several advantages of the, shockwave system to treat the calcification. One thing is that it's not so complex compared to the rotablation system. And one thing is that, for example, if you are using a relatively large burr with several rounds of the rotablation, we worries, for example, the slow flow phenomenon, especially under this kind of a situation. This is, heart failure patients suffer with heart failure. So we do not want to see some. Okay, we can see that there is a focal under expansion
6.
under the full atmosphere of the IVL. And we have finished the second round of the shock wave at this current spot. I think maybe, two, for example, one or two more round at this spot is potential of advantage. So maybe we need one round at the relatively distal part. That spot
6.
is not well expanded. And you can see that two wire in the two diagonal branch is the potential of field wire to protect the two very important large set branches during this kind of procedure. And also, I was indicated that at the proximal part of the
6.
RAD, there is also diffuse the superficial calcification. So we need to use this one balloon to make an therapy along the whole vessel. Maybe one more round at the bifurcation side, because we just see that it's a little bit focal under expansion with the balloon here.
Okay. After this one.
Okay. And we can see that using this IVL, the patient is relatively stable with the support of the IBP system.
6.
And the heart rate, the blood pressure is relatively okay. Nowadays that we can see there are several case reports and several clinical trials to detect the combination uses of rotablation and the IVL system in the severe calcified, lesion and calcified patients. So I think that nowadays with the development of the equipment and technologies, our strategies to treat the severe calcified lesion is being different compared to
6.
the 1 or 2 decades ago. Nowadays that we have some modification, plaque modification balloon, and also we have the rotablation system. We have the IVL
And
system.
the first diagonal. Okay, here.
Yeah.
This position.
Okay, I think that this part requires 1 or 2 round.
4.
I think we can use the rest of the round here. Yes. For my visual estimation, I think that this part is already, much better compared to the initial,
6.
IVR round.
Better now.
Yes. Seems to be much better.
Yes. Maybe another round here.
So what we are demonstrating here is that we can see the IVL system is relatively maybe potential, therapeutic strategies for this kind of relatively large vessel caliber, but with a severe circumferential superficial calcification, and also there might be a potential calcified nodule at the 7 o'clock by the IVUS image system. And this kind of IVL system, we can see is relatively very simple, very quick strategies to treat this kind of a chip patient without blocking the vessel blood flow for relatively too long time, without causing too much potential risk factors for the slow flow, which is also, indicate predictors for the peri-procedure myocardial infarction. And now we are making an angio to check the flow of the vessel. Okay, it's very good, I think. There is no sign of slow flow. And also, I think that the most severe part under the IVL, there is no severe dissection. And also, the vessel diameter has been already, much better compared to what it is before. Maybe we give some vasodilator and then check the IVUS again to
Yes.
see what, yes, we have engaged. I think Professor Zhao has made a very good demonstration in this case of how to make the application of the IVL system in this kind of a chip patient. We can see with some short round of the balloon dilation and also the shockwave therapy, this kind of superficial calcification can be well, controlled and well managed with low risk of slow flow and vessel dissection, which is something that we do not want to see in this kind of a patient. And now Professor Zhao and Professor Dong is sending the IVUS catheter inside, and we can once again to see how this kind of a new, IVUS system collect the image with a relatively very clear, very sharp border of the vessel, and also very quick pullback speed. One thing that I missed from the just the introduction of the
Okay.
IVUS image, we can see that the pullback speed we have 0.5 millimeter per second, we have 1 millimeter per second, and also we have a quick scan mode using the 1.5 millimeter per second. So we can see that okay, maybe this is a potential, landing zone that we just see. This is the second diagonal wire joining into the main vessel. And this is the first diagonal. Okay, we already see some crack, I think, especially at, okay, here is some crack. I think after the shockwave system, we already see some superficial crack as a calcification. I think this is a good sign for the stent expansion, for the potential good stent expansion. And this is the proximal part of the LVD. This is another bifurcation joining inside, and this is the proximal part of LVD. Okay. Maybe we check again.
30 NC balloon.
Okay, let's check again of the IVUS image, and this is just the potential landing zone that we just detected from the previous IVUS image, and this might be a potential of 3.0. Stent for the first one, and this part, this is the most severe stenosis part. This part we doesn't see too much of the calcification, so this is not our target for the IVL system. However, we can see that after the 2.0 balloon predilation and also the IVL system, we can see some well controlled. There is no severe dissection. This is, I think, one of the advantage of the shockwave system. We do not open the balloon to a relatively very hard atmosphere. This is good because we are not using the IVL balloon for dilation or for plug modification. We are going to use the full atmosphere to make the balloon well attached to the vessel wall so that the ultrasound wave can be well,
Okay.
transmitted to the calcification part. Okay, I think this is a spot of the good demonstration here. We can see this part at the 9 o'clock site with the superficial calcification. There is a clear spot of the crack of the calcification after the IVL. I do not think this is due to the balloon dilation because we can see, although IVUS image cannot detect the thickness of the calcification, but we can see this part using a full atmosphere is less likely to make this kind of crack. So we give this kind of result to the function of the shock wave system. This is one crack that we can see very clear from the IVUS image after the IVL system. And I think one more thing we need to emphasize is that maybe sometimes after the shockwave system or IVL, we do not see, how to say, very clear crack like this one. The two sheets of the calcification, got disconnected. Sometimes it's only a small crack, But also this one works. We are making the plaque modification for the stent expansion, but not tear the whole intima and also the media of the vessel. So I think that this is a one good, very important teach point of how do we modify the calcification. And here is the proximal and also the distal
Okay.
proximal and made part of the LVD. I think after the second diagonal branch where joining into the main vessel, we can also see some crack later as the proximal made part of the LVD.
26 or
The proximal
30.
LVD,
Okay.
this is a relatively very large
Okay.
vessel.
美德利
Okay.
26或30。
Okay, I think that although it is not very clear, but we can see some potential hint here for the crack, for the black crack.
105 millimeter balloon.
Okay, maybe here. This is the potential calcification crack at the
Totally.
superficial part. Let's check the proximal part of the landing zone of the LVD and to see the length. For the peri procedure, we measure the length for something like 60. I think this one is still the same, something like 60. The first one is something like a 3 millimeter stent, 3.0 millimeter diameter in diameter stent. And the one as a proximal LED, I think is a 3.5.
Yeah.
However, like Professor Zhao is doing, that we need some further plaque modification. So yes, maybe we need to dilate the whole vessel, I mean, very precise later before the stent implantation.
Oh, okay.
So by the second IVUS, we found that after the IVL system, we see some very clear crack of the superficial calcification. And I think this is a good promise for the good stent expansion.
The second diagonal, huh?
Okay, so you just do the modification with 3.0. Yes, okay.
Yeah.
Yeah, okay. So what kind of balloon did you use for the plaque modification?
105 balloon. The first blue. 来，你抄一下。
Okay, now that Professor Zhao and Professor Dong has finished the plaque modification using a 3.0 balloon, and now we are checking the
diagonal 是吧？ Yeah. 抄哪个？我 know 那I know.
So, Professor Dong, what kind of scoring balloon do you prefer for this kind of superficial calcification in your daily PCI work? I mean that what kind of scoring balloon do you prefer to use in your daily PCI work?
Cutting balloon.
Yeah. During the modify plaque burden, we also use some scoring balloon, NIC balloon, or cutting balloon. Yes. In our operation, I prefer to use the NIC balloon to modify the plaque burden because it's very easy to go through the very narrow legend. So we always like use the NIC balloon.
Pressure. Okay, new run, please. Okay, we are making the third IVUS run to check what's the plaque situation after the plaque modification using a 3.0 balloon. Okay, still we can see that there is a lot of, very diffuse lesion in the distal part of RAD. However, this is not our target lesion because nowadays we have some good modification for the plaque stabilization and also the how to say make the plaque this kind of long diffuse latent stable. Okay, we can see some maybe very controlled intima dissection after the balloon dilation. I think this is also the good prognosis for promise for the well stent expansion. This is after the first diagonal joining inside. Okay, we can see some crack just as in 9 o'clock part. And we can see the proximal part of the LVD. We can see some superficial crack of the superficial calcification after the balloon dilation. And this is coming to the proximal part of the LVD, the potential landing zone. Later we are just going to see. I think the plaque has been well modified with some controlled intima dissection, but it's not so severe. Okay, we have coming to the left main already. Okay, let me stop.
好，OK，
Okay, let me check again the whole EVS run. Okay, once again, the distal landing zone. Okay, I think maybe this is the potential, the landing zone. I think we didn't check the very clear set of the distal landing zone because the distal part of the RVD there is long diffuse lesion. And also here, okay, with the 3.0 balloon, here we can see some well-controlled intima dissection here after this 3.0 balloon, but we can see it's controlled. It's not beyond the EEM. So this is also the good prognosis for the stent expansion. However, we noticed that the plaque burden of this patient is so severe, and also some controlled superficial calcification crack. And also, I think that I just found something here at the 9 o'clock with some superficial circumferential, yes, here, calcification crack after the IVL and also the plaque modification.
哎，扩一下。
So my suggestion is that maybe we use we use a cutting balloon or something to make further plaque modification before the stent implantation maybe. So how about a cutting balloon, maybe 275 or something? So what do you think, Professor Zhao?
1.5的小球呢？cutting balloon？
maybe 275 cutting balloon.
Yeah.
Okay.
OK。先扩一下。扩一下球呢。
And also, like I just mentioned in this case, that there are two very large diagonal branch in this RVD, and also these two diagonal branch as a proximal part, and also the ostium of the diagonal branch with a severe focal severe stenosis. So I think that it is of key importance to maintain the flow of these two very important diagonals. And also we learn from the previous manuscript that the recanalization of the RVD in the triple vessel disease patient is of key importance. Because one thing is that the RVD is of key importance in the left ventricular function. And the second thing is that also the diagonal branch is of key importance.
OK。10。OK.
Okay, I think that here is some questions from the audience online. I think that there are two our dear audience that is very how to say interested in, very focused. They pay their attention to our blood pressure. They also indicated that the transducer for the blood pressure does not seem to be accurate. Thank you. We thank you for your concern and help to our PCI procedures. I think I'm going to explain what we have seen earlier for the blood pressure on our introducer. Okay. One thing is that with the help of the IABP system and also our well-controlled of the medication, the blood pressure and also the situation of our patient is relatively very stable. Actually, before our procedure, the patient lies on the table and we can see the heart rate is over 105. And also the blood pressure is relatively low, like a 90 or something. However, after the IBP system is engaged, we can see the heart rate and blood pressure is, much better. just before when we are
Okay.
using the IVL system and also the IVL system, maybe due to the deep engage of the guiding catheter, blood pressure seems to be a little bit, not correct. But what we can see after we adjust this position of the
Okay.
BL guiding catheter, we can see that the blood pressure is, fine now. So thank you for your question. It's due to the deep engage of the guiding catheter, which makes the blood pressure value doesn't seem to be right.
Okay.
And the next question is, what is the purpose of the wire in the first and second diagonal? Thank you for your question. What we have seen is that now Professor Zhao just used a 1.0 and a 1.5 balloon to make some dilation at the ostium of the first and second diagonal. So our wire in the first and second diagonal is the purpose of drilling wire to protect this very large, very important diagonal branch during the, our procedures. Because we learned from the previous manuscript that the losing of this very important, for example, the length over 90 millimeter large bifurcations is of a potential, disadvantage for the prognosis of the patient. Because if a very large bifurcation with a length over 70 millimeter, which means its perfusion myocardium area is over 10%. So losing this kind of very important set branches is, very great risk of peri-procedure myocardial infarction, and also is a good, very important damage to the heart function of the patient. And the fourth question, are there any specific technical considerations or challenges associated with using our IVL system in this case? I think this is a relatively very good case. I'm going to, introduce my personal, skills. For one thing is that the IVL system is of a potential very quick and very friendly to the clinical usage, especially for this kind of a chip patient, because we see the heart rate, the heart left ventricular function, and also situation of the patient is not so stable compared to the other patient. So IVL system is a balloon delivery and also the ultrasound wave transmission is relatively friendly. Currently, we do not see some very high risk complications. For example, it doesn't cause slow flow. It doesn't cause very severe dissection. So this is all advantage of this kind of a system in the chip patient clinical usage. For example, we know that this is not, an rotablation favorable, case in this kind of superficial circumferential calcification. However, we know that there is a potential of slow flow or non-flow situation after the rotablation in the chip patient. So I think in the usage of IVL system is relatively more friendly compared to that. However, we are not saying that the IVL system is a 100%, can deal with all the cases of severe calcification. For the cases of calcified nodule and also the severe circumferential, especially 360 degrees calcification with small vessel caliber, I think still rotablation is of a strongly recommendation for this kind of situation, especially the balloon or the other devices cannot pass. However, the IVL system is a good, situation of clinical usage in this kind of chip patient. Challenges associated with IVL. I think the only challenge for me, for my clinical usage, is the delivery of the IVL balloon. We know that there are some very complex facilities which is within the IVL balloon to give out the ultrasound wave, so that it's outer diameter and also the the passing through the IVL balloon is of a potential difficulty. So we can see that Professor Zhao just used the 2.0 balloon to make some pre-dilation before we put the IVL balloon in. The next one, have any other treatment options, such as rotahysterectomy or plain balloon angioplasty, been considered? Yes, thank you. I think that our procedure has been well indicated that before the IVL balloon, we use a 2.0 balloon to make some predilation. And also one thing is that to allow the IVUS catheter to pass to check the situation of the plaque distribution and composition. And also we use a 3.0 balloon before the stent implantation after the IVL system to make the well plaque modification before the stent was implanted. Did you consider surgery? Yes, thank you. This is a good question because of the limit of the time, because we should shrink our time within 1 hour. And so we didn't make some very detailed introduction. And for this patient, we noticed that it is a relatively very small circumflex. So I think that the surgery, I mean bypass graft for the small circumflex doesn't seem to be a choice. And also, if you pay more attention, you can see at the distal part of the RAD, there is a very focal severe stenosis. So I think that CABG for this kind of very small vessel caliber is also not favorable. So I think that CABG for this patient is a potential choice, but maybe not first, recommendation for the patient. So thank you for the questions of the audience online. And now we can see that Professor Zhao has just finished the implantation of the first stent. And from angiography, we can see it's well expanded. So we give this kind of good result to the good clinical usage of the plaque modification combined with the IVL system. So what's the size of the first stent, Professor Zhao? So what's the size?
30 millimeter, 26.
Okay, thank you. So this one matches what we measured from the IVUS system.
组位
And let's check again the what we have seen. I think, for my opinion, for the previous one, our measurement is something like 60, and the first one is 3.0. Okay, the first one is 3.0, and at the second IVUS run, we check the total length is around 60, and the second stent might be something like 3.5.
Okay.
So let's make a fourth IVUS run to check the rest of the plaque and also check what the second stent, the length and the diameter. And also, one thing very important is that to maintain the blood flow in the two very large, very important bifurcation.
好。好 ，OK。
Okay, pull back, please. Okay, pull back. Okay, we are pulling back. Once again, we can see the mid distal part of RAD. There is some long diffuse lesion. Like what I just indicated, that I think currently we have very good medication for this kind of patient. We have PCSK9 inhibitor. We have some other very good medications to treat this kind of a long diffuse lesion. I think we need some post dilation. And also, yes, at the most severe, plaque burden part, we need some, very good post dilation. But I think the distal edge is fine. There is no signs of dissection, no hematoma. So we need some NC balloons to make some well expanded of this first stent. Here is some circumferential, very high plaque burden. And we checked the second length of the second stent. I think the second one need to cover to the proximal part of the RAD near the ostium to cover all the plaque burden. Okay, can we see where the IVUS is now? 透视一下。Okay.
Oh.
Okay, we have finished. Let's measure what's maybe we make the post dilation first, or do you want to I mean, after the second stand we make the post dilation?
先扩吧。
Okay, so maybe we make the post dilation first.
我这个
Let's connect to the first one for something like 3 millimeter, and then we see the length.
导丝，刚才那个导丝我再记，给看能不能进去。
So how about 38 by 3.5?
38 啊，OK。
Okay, because the first one is 20 something, and the total length is over 60, so maybe 38 by 3.5. And we notice that after the first stenting, the second diagonal is still patent. I think this is a relatively good sign, because like what I just emphasized, keeping maintenance of the two very large bifurcations is of key importance in this kind of very severe, I mean, chip patient, because it's a good promise for the prognosis of the patient, especially for the patient with a low EF ejection fraction value.
New ensemble. Yeah.
And also, I think this is a good demonstration to see that from angiography, we see the first stand is already well expanded. However, from the IVUS, we can see that MSA is not so favorable. So NC balloon post dilation is of key importance and cannot be deferred during any kind of PCS strategies. I think this key point has been well taught through all the manuscript and also the case demonstrations through the intravascular imaging system. And today we are using the 100% domestic software made by the Beijing company called let me check the name again. It's called the Insight Left Tech. We can see very clear and also very sharp border of the vessel lumen, and also we can see the stent thrust very clear. The pullback speed is relatively fast. We can make a 1.5 millimeter per second pullback, and also with a super land pullback length over 1.5 meter, 1.5 150 centimeter of the pullback length, 150 centimeter pullback length. So this kind of a super long pullback length and also the very quick pullback speed is a good guarantee. I mean, for this kind of a chip complex cases.
OK.
Okay, we make some good, NC balloon post dilation for the first stent, and then later we are going to put the second stent in to cover all the most severe heavy plaque burden lesions as a mid proximal part of the RAD.
OK. Oh.
So we can see that we just use one 3.0 IVL balloons to treat this kind of lesion, and we get some good prognosis. And also nowadays we know that we have some the calcification evaluation markers based on the IVUS and OCT system. We know that IVUS cannot detect the thickness of the we know that the IVUS cannot detect the thickness of the calcification. However, the OCT can, but this is not the restriction of the IVUS application in the calcified plaque. I think the advantage of the IVIS is that it's a very high sensitivity and accuracy in detection of the calcification compared to the OCT system. And we know that Professor Zhang Mingyou in China has just published a manuscript to give the evaluation under the rotablation system usage in the severe calcification cases. Here is some markers, for example, whether it's a 360 circumferential calcification, whether it's over 270, superficial calcification with a diameter of smaller to the 3.5 or not, and whether there is a calcific nodule. These are all indications for the clinical usage of rotablation system. However, I think that during the clinical usage of IVL system, we are going to collect more and more data, and also more and more study results is going to review, compare the instant and also result of the severe calcification prognosis. Actually, there is one very important and very interesting question that I used to ask for the other professors. We know that currently there is so little data to indicate the clinical plaque modification, for example, the rotablation and also the scoring balloon, to make some development to the prognosis of the patient. For example, it reduces the myocardial infarction rate in the calcific, and also to reduce the myocardial of the patient, and also the reduce the all-cause mortality of the patient in the calcified patient. Why there is so little data in this kind of facilities application in the clinical usage? I think that here is some explanation. One thing is that nowadays, under the good medication system, we have already dramatically reduced majority of the risk factors in this kind of a patient. And the second thing is that maybe there is still, how to say, some distance that we can acquire, not only to make the well expansion of the stent, but also I think that, for example, during the usage of the IVL, we will reduce the rate of the slow flow and also the non-flow, hazard ratio. And also for this kind of IVL usage, we reduce the potential dissection, very large hematoma. And all these things also reduce the risk of losing very large bifurcations. I think that these things is a good promise for the development of a cardiac death and also the all-cause mortality for the patient. So I think that maybe during the further studies, and we can acquire some different result compared to the previous manuscript in the clinical prognosis of the patient in the severe calcification and maybe in the chip patient. So this is my personal explanation for this kind of phenomenon. And now we can see that Professor Zhao is trying to repair the first diagonal because the flow doesn't seem to be well. This is within our consideration because before the procedure, we can see the ostium of the first diagonal is already severe focal stenosis. We know for the angiography studies and also the intravascular imaging studies, the focal severe stenosis over 90% and also the long lesion length over 10 millimeter is all strong predictors for the acute third branch compromise during the clinical studies. And in this case, we can see the second diagonal, its caliber and its length is all relatively larger. So we think that the second diagonal is more important in this patient. And also after the first stenting, we can see the second diagonal is patent. So this is within our consideration. And sometimes we can see that in this relatively small, short, diagonals, it's relatively difficult to maintain the blood flow. Once again, like the questions from the audience, two audience all, pay their attention to the blood pressure and also the heart rate. We can see the blood pressure and heart rate of the patient is quite stable. sometimes the blood pressure dropped dramatically is due to the deep engage
那个
of the
位置也
getting
可能
catheter.
对，那就来把它扩一下，可以扩一下，扩一下，好了。
Okay, we are trying to use a small caliber balloon to make some dilation of the ostium of the first diagonal, and then we are going to try to put the second stent in.
好。
And Professor Zhao, we noticed that there is a focal stenosis at the distal part of the LAD. Do you consider potential usage of DEB for this spot later?
Okay. We will later use the IVL to assess the distal LAD. If the vessel size is more than 20 millimeter, we will use the DEB to treat it.
Okay, thank you. This is one question from the audience. So I think that, like the Professor Zhao indicated, that after the 2 stenting implantation, which can recover the blood flow and also is a good guarantee, I mean, for the situation of the patient. Later, we check the distal part of the LVD. If the vessel diameter is around 2 millimeter and there is no large severe dissection or hematoma, maybe clinical potential usage of DEB for this kind of diffused small caliber vessel is a potential therapy strategies.
Okay. Little. Okay. 有点。好 ，OK。
直接放掉。
行，
这个小。
Another stent.
Okay, maybe we try to put the second stent in. 这个是掏支架板眼过去还是？那得拿出来，是不是？Okay, we try to put the second stent to connect it with the first one, and then we check IVL again to see the stent expansion. I think the current situation is fine. Like we just emphasized, the second diagonal, the caliber and also the length is relatively larger compared to the first one. So we do not worry too much about the first diagonal because its length doesn't seem to be over 70 millimeter, and also the vessel caliber is so small. Okay, from the measurement of the IVL, the second one should be around 3.5 millimeter stent by 36. We need to retreat the jailed wire in the first diagonal because it's a rewired wire. We do not want to make the jailed wire in a sandwich structure because the wire doesn't seem to be a good choice within the 2 layers of the metal stands. This may make a potential jailed of the wire. Okay, I think yes, we can see that the first one might be connected already. Maybe we see from the cranial view. I think that it's already connected. Sometimes that this kind of severe calcification is hard to detect. Okay, I think it's already connected. Okay.
Okay.
After